My name is Dr. Pascale White. I'm an assistant professor of medicine in the Division of Gastroenterology at Mount Sinai. April is National Minority Health Month, and today I will be answering questions regarding colorectal cancer. So, colorectal cancer is cancer of the large intestine or colon, or the rectum, which is the end of the colon. So, African Americans are about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most other groups. And so, they have the highest incidence, highest mortality, and the lowest survival. And it's not entirely clear why this is the case. We do know that risk factors and social determinants of health make the obstacles in the African American community very complex. Screening rates have been very low in this community due to many barriers, including patient-related barriers such as lack of health insurance, access to primary care, other sociodemographics, and even physician barriers such as lack of physician recommendation as well. So while we do know that this is impacting the community, there's a lot more we can do to make it better. So about 80% of colorectal cancers start off via what we call the chromosomal instability pathway, where normal tissue undergoes a series of mutations that allow for the abnormal tissue to grow and grow until it forms a malignancy. Well, screening. Screening for colorectal cancer is the number one way to prevent it. And if caught early, colorectal cancer has a 95% survival rate. And there are many ways to get screened. You can get screened via colonoscopy, which is one of our invasive tests where we insert a camera to take a good look around the lining of the colon to find any growths or polyps. Or you can have non-invasive colorectal cancer screening via stool-based tests that you can take at home and drop it off at your doctor's office. At this point in time, everyone 45 years of age and older that's at average risk for colon cancer should be screened. Anyone who has a family history of colon cancer or may have certain genetic syndromes may need to be screened much earlier, but as of right now, 45 is the new 50. Well, at this point in time, what we do know is that there is a rising annual incidence of colorectal cancer in patients below the age of 50 years old. A lot of people reference the actor Chadwick Boseman, who developed such a disease in his 30s. And while we don't know the exact circumstances or risk factors that may have led to Chadwick's early onset colorectal cancer, what it did show us is that early onset colorectal cancer is happening. And so, for example, in the mid 1980s, patients between the ages of 20 and 29 saw their incidence increase at 2.4% per year. And those 30 to 39 in that age group saw a rise of 1% per year. And what we see is that compared to adults born in the 1950s, patients born in the 1990s have a twofold increased risk of colon cancer and a fourfold increased risk of rectal cancer. So while we still don't know why this is happening at such a young age, whether it's environmental factors or other things, research is still ongoing for this. So the first thing I'm looking for is any types of growths or we call polyps on the lining of the colon. These can appear very differently, from very flat polyps to very large growths. And so the most important thing during the colonoscopy is to make sure that you are completely cleaned out and to take all of the medications that we're giving you in order to have a great bowel prep, and so that we can identify even the smallest of growths on the lining of your colon. Well, the best screening test is the screening test that actually gets done. And so we have a very big choice that we make in terms of getting screened, and patients have choices as to how they want to get screened. So you can go through, as I discussed, a colonoscopy, where it's a more invasive procedure that involves coming into a hospital setting, possibly getting a little bit of anesthesia, and also having to have that intervention of looking for polyps and removing them the same day at the same time. A non-invasive test like the stool test, we think about our fecal immunochemical testing or FIT testing. We think about Cologuard, which is a FIT DNA test. These are all things that you can take at home and drop off to the doctor's office after you've submitted the sample. So all in all, it's a screening test that you are willing to do and that you actually get done. At Mount Sinai, we have a program called Choice, Your Colon, Your Choice, and that gives you choices for your colorectal cancer screening. So the health system offers 3 types of screening tests: the colonoscopy, the fecal immunochemical test, or the FIT test, as I discussed, or a multi-target stool DNA, also called the Cologuard, which is a combination of the fecal immunochemical testing as well as looking for DNA cells in the stool. So if you're 45 years of age and older and are at average risk for screening, you qualify for a screening test, and you should call 212-824-7887 for an appointment. When you call, our centralized access center can further discuss your screening options, schedule a screening examination, and you can find out more about your upcoming exam at that time too.